Oh, there we go. Morning, morning. Thank you very much. Thank you, David. Welcome back, everyone. And yeah, we're on the lumbar spine at the moment, and we should finish off the ligaments, connective tissue, and then but this kind of section is a passive structures section, so we'll have a look at spinal discs as well. Hopefully should be able to get to that, and then we'll, before we move on to the musculature, so we'll do that first. As always, if you have any questions, then you can pop them in the chat. If you're part of our private Facebook group, then you can put them in there during the week if you're watching on catch up. And if you've never watched this before, then basically we go through every part of the body from the bones and joints, and then we add on each layer as we go through each section. And then once we've filled that section, then we go on to the next one and do the same again. And this is now the 240th time I've been doing that. So yeah, it's we've got quite a bit of content there on YouTube. Right. Thank you, David. Thank you very much. Right. Without further ado, let's get going. So we're yeah, we finished off last time. We were having a look at this, something called the ligamentum flavum, and it was basically called that because it's the yellow ligament, and we were having a look at the orientation of where it was so that you could kind of get your head around it. But one of the key things was this. Just trying to get there we go. So this is the body of the vertebra, and then this is the view that we're looking at. So cut through the pedicles. And if you're not sure what these are, then we went through these over the last couple of sessions. So have a look back at, I think it's episode 238, where we go through the bones and the joints. Yeah, so we've got cut through the pedicles there, and then the view is that way. So that's the arrow direction of the view. So we're looking at this bit here is the cut pedicle, just there and there, there and there. So what would be in front of these is the vertebral body, and then that's been taken away. And then what we're looking at here is the lamina at the back, which is this bit around here. Okay, so that's where the ligamentum flavum are. They are so called. Sorry, I've just I wonder if it's going to mess around again. I did this a little while ago, and yeah, sorry. Is whenever I switched onto the video, it muted my sound for some reason. Right, start that again, just in case you didn't hear bits. So we've got the vertebral body just here. These are the pedicles, so the little feet coming off of the body. Thank you, Steph, for the heads up. And this is the lamina at the back and the vertebral foramen here, where the spinal cord will go through when we get to that section. So that's the view that we're looking at. This is an image that you will show you this a few times, actually, because there's some other ligaments we need to add on as well. But these are the vertebral bodies. Those are the discs. You can see the connection up the top here where it's been left on, and then down here there's been a slice taken through those vertebral bodies so that you can see halfway through, and then that's where the ligamentum flavum are there. Okay, so they're on that back side. This is an image from Trail Guide to the Body. So if you have that book, then that is a really good book. If you don't, then definitely worth getting if you're learning anatomy. This is the pedicles down the side, spinous processes at the back, and then this is your view. So that's what we were just looking at. I'm just going to pause that there. That's what we were just looking at on the last slide. So those are the ends of the pedicles where they've been cut. So the vertebral bodies would normally be here in front of what we can see. There's a transverse process. That's the lamina just there. So there's vertebral body. Those have been taken off. And then what we're looking at is kind of inside of the vertebra, just there on that image at the top. Okay, so there's your ligamentum flavum. So pedicles, there's the ligament in between. Okay, so again, it's called the yellow ligament, ligamentum flavum, and that is why, because it is very yellowy in appearance. And you can see it's quite thick, really. It just fills that gap in between the lamina, so provides that structural integrity going into flexion. So I was saying last week that this ligament is often mentioned on MRI scans, because if you have a car accident where you have a whiplash, where you've got hyperflexion, then this ligament prevents that movement. But obviously if it's a bit quick, then it can injure that ligament. And if there is an injury to it, then it will start to heal itself and lay down scar tissue and increase in size. And you often will get a comment on a scan saying ligamentum flavum hypertrophy. So basically the ligamentum flavum has grown a bit. And the problem with that is if this increases in thickness, then it will encroach on the vertebral foramen, which is where your spinal cord is. So that's why it's usually mentioned on scans. So that's why we've got this in here. Just play the rest of this video out. So yeah, there's the lamina there. Oh, there wasn't much more to play out. There you go. So that is that one. Is it still working? It is. Good. Okay, I'll check the sound every time I switch. So that, yeah, there's your lamina, there's the ligamentum flavum, and then lamina, ligamentum flavum. But what you will have hopefully seen on the video of the real dissection is the fact that the ligamentum flavum doesn't stop like it shows in this image. Yeah, it is continuous. There was a little bit of a gap where you can see this coming through, see the bone coming through, but then it was pretty much continuous. And this goes all the way up the spine. So although this is the lumbar spine section, the ligamentum flavum goes all the way up. Hi Becky, hi Lizzie, good to see you there. Right, so the last ligaments to look at, just move me out the way. There are two, and they're called longitudinal ligaments. And they are called that because they are pretty long. So here is again nice clean image. This is from Trail Guide to the Body book by Andrew Beale. So again, if you want to have a look at these images, then definitely worth getting that book. So here's your vertebral body. This is the anterior, so it's at the front, longitudinal, because it's pretty long, ligament, because it is ligamentous tissue. So we've got anterior longitudinal here. So you can see it wraps around the vertebra, and they've separated it halfway along between anterior and the posterior side. Well, so you can see the disc as well. But really, this wraps around the whole body. Yeah, so when we see it for real, you'll see that in a second. And then this one here, this is the posterior longitudinal ligament. This is literally is smack bang on the back of the vertebral body. So if we have a look at a top-down view here, yeah, so that this is the line of the cut of the image. So we can see these little dots here because the bone's been cut. There's a spinal disc, a vertebral body, spinal disc. There's your ligamentum flavum, which is what we saw earlier. That's a pedicle. So that's the little feet that come off the back. And then there's the lamina. And there'll be another one on this side which links the two. So like in that picture just there. And we do have some other ligaments here. A couple that we are gonna, I think we might have videos for all of them actually. So we're definitely for this one. So we've got a supraspinous ligament, which is all there. See that one just there? So if you have a feel of someone's back and you can feel the spinous processes poking through, which are these bits here, then you've got the skin, you've got subcutaneous fat, then you've got supraspinous ligament, and then you've got the spinous process. So there's a few layers over that area just there. And if you've ever done anything like cupping, that kind of thing, where you, or like skin rolling type techniques, myofascial release type stuff, you'll notice that if you do some work over the spinous processes, if you're using cups especially, it doesn't lift as well as either side of the spinous processes, and that's because of the connection of this supraspinous ligament and the tissue above is kind of like connected into that spot. So as you're going over, it just doesn't lift as much because of the connections there with the ligament here. And then in between the spinous processes, so there's a spinous process, there's another one, there's another one. We've got this one, which is the interspinous ligament, so in between the spinous processes. So there's quite a lot of ligamentous tissue all wrapped around the spine. So we've got anterior longitudinal, posterior longitudinal, ligamentum flavum, interspinous, supraspinous. Those are from the front to the back, all of the ligaments that are around the, and that, well, say all of them, there are some others as well, but really small ones that connect the transverse processes. But yeah, those are the main ones usually for exams, and definitely on things like MRI reports, that kind of thing. You will usually hear those names in those image reports. So that's the images, and then let's have a look at some of these. So this is the interspinous and supraspinous ligament, or ligaments, two separate ligaments. So interspinous and supraspinous, so the one that in between the spinous processes and superior to, so that's why they're called supra. Looks as if my thing's still on, so that's good. Sound is still coming through my end, so hopefully it is for you guys as well. So we've got the transverse processes just here. There's your vertebral body, and then vertebral disc in between, and then we've got a spinous process at the back just here. And can you see that tissue just coming through there? So keep an eye on that as we go around. We go, there you go. So we've got interspinous ligaments in between the spinous processes. See that white glistening structure just there. So there's your spinous process, there's another one just there. There's the supraspinous ligament on the top. So you can see it's quite a thick ligament connecting all of those spinous processes together. Transverse process just here. And then vertebral bodies and vertebral disc, which we'll have a look at. We should have time to have a look at that today. These are your foramen, transverse foramen on the side of the vertebral bodies. Let me just play that through. So that's where your nerve roots are going to come through when we start to add that layer on there. So here, that section there, that's a pedicle. So that's the little feet coming off the back of the vertebral body. The inferior part of the pedicle, so the bottom bit of it, is curved upwards. There's another pedicle there, and the top part of that is curved downwards. So then it creates this hole when the two join together, and then the nerve root will come through there. Right, so we'll add that on as we go. So that's the interspinous, so in between the spinous processes and supraspinous ligament. And then we've got the posterior longitudinal. Now this is really useful to know about when we are just about to go on to discs, okay, and have a look at spinal discs. All right, just pause that there. So quick orientation again. So this was the image that I showed you on the slides. We had vertebral body, vertebral disc, vertebral body, vertebral disc. Anterior longitudinal was at the front, and we can see that cut section of it just there. And then the posterior longitudinal was on the back of the body. Okay, so it's that bit there. So there's the body. There's the pedicle. There's another one. So the posterior longitudinal ligament is along that bit there. Okay, and connects every single vertebra to each other. So we're going to take off these spinous processes. So we're going to cut through the pedicles again, and this time, instead of flipping it and looking the other way, we're going to and look at the ligamentum flavum. We're now looking at the back of the vertebral body, and then there's your posterior longitudinal ligament. Okay, now the reason why this is important is because some classifications of disc herniations are given certain names depending on whether they've breached this ligament or not. So we'll talk about that when we get to the discs. And it's the reason as well why commonly we have disc bulges posterior, lateral. So they come out backwards and then to the side. Yeah, so the disc is obviously around this area here, so behind this ligament. So if you have a herniation of a disc and it's coming out the back, it will hit this posterior longitudinal ligament. Yeah, and because this is really tough stuff and the back of the annulus is the weakest part of the disc, then the nuclear material, because it can't get out the back, will then migrate to the sides, or more likely to migrate to the sides. So that's why we usually have disc bulges around this area here and this area here. So and centrally is relatively unusual. Obviously they do happen, but you're more likely to get these side to side herniations just because of the structure. And we've got pedicle here. So if you remember, the pedicles were shaped like there was a dip on the top and then an arch on the bottom. So you've got then that transverse foramen, so with the holes on the side. So those would be here. Yeah, and remember I was saying that's where your nerve roots come through. So if the nerve root is coming through here, and then that is where it's more likely to herniate and release disc material, whatever it is, and we'll, like I say, we'll have a look at that in a second. Then that is the reason why we will get irritation to the nerve roots because of a herniation to a disc. Okay, so the posterior longitudinal ligament protects the spinal cord. Yeah, it's there as a barrier for it to not encroach on the spinal cord or the cauda equina in the lumbar spine case. So that runs down here, and the structure makes sense or helps make the sense of the reason why we get disc bulges where we do. Okay, just because of the orientation of the fibers and the structure of the ligaments and the structure of the disc. Okay, so we've got attachments onto the disc as well, so they physically attach onto it, and they extend somewhat, but yeah, there's your vertebral body, and then the disc in between. So that's the posterior longitudinal, and then the anterior longitudinal looks like this. So this is the one at the front. Just check, yep, microphone's working okay still. Okay, so there we go. So again, on the image, it looks really nice and neat. This is an amazing dissection. To be able to dissect this out is quite phenomenal. So you've got the vertebral discs, and yeah, if you want to see these videos, they're from the Ackland Anatomy bunch of videos, really good. There's your vertebral body, there's your disc, that's the anterior longitudinal ligament all the way along. So on the image, that's it, just along there. Okay, so that's what it looks like in real life with everything else removed. So you've got this anterior longitudinal ligament, but can you see it wraps around the whole thing? It's not just on the front. So they're going to cut out the midline, there you go, and that's what it looks like underneath. Yeah, so vertebral body and disc, and again, it just cocoons everything and attaches down the front of the vertebra. So as in that image, helps to limit hyperextension in this case. So if you have a look at the supraspinous, interspinous, ligamentum flavum, posterior longitudinal, 4 ligaments, all helping to prevent hyperflexion, and the 1 anterior longitudinal preventing hyperextension. Okay, so that's the layout, if you like, of all of those ligaments. So, and again, that's what it looks like in the book. So anterior longitudinal, posterior longitudinal, ligamentum flavum, interspinous, supraspinous. So that's all of those ligaments front to back. Hopefully that all makes sense. We're now going to have a look at spinal discs. And this session probably takes over 2 sessions. I've done it a couple of times before, so it might be a bit of a revision session for some of you. If you're brand new to it, again, if you've got any questions, then give me a shout in the chat. There's no problem at all. So some of this will be a bit of myth dispelling because there is quite a lot of stuff talked about with especially examination of disc problems. It's not as easy as we think it is, and it's not as straightforward as we think it is. So, and also this is really useful for when you're doing neurological exams. So when we'll do a session on sciatica as well, which will link into this. So knowing this stuff will help the sciatica session make sense, hopefully. So this is what your disc looks like. We have a nucleus pulposus, which is like a kind of jelly substance, really. It's not liquidy, it's more I don't know, it's a bit like a jellied eel kind of thing. And then you've got your annulus on either side here. So annulus fibrosis, if you think of annual, means like all year round. So we've got a round structure around the nucleus that is fibrous. So annulus fibrosis. This annulus fibrosis is orientated in lots of different directions to give the disc integrity, structural integrity. If you think about if we had all of the annulus going in one direction and then you twisted in the opposite direction, it would just open like, I don't know, like turning a screw. Yeah, because if you don't have things going in opposite directions, if you move in the and there's no integrity going the other way, it's just going to twist the whole thing. So the way that these discs are orientated is to withstand forces in lots of different directions, compression, distraction, as well as side bending, rotation. Yeah, so the design is really quite unique. We've got these things here called end plates. So that bit there, and then that bit there. Those are really key to have a look at. If you've not really studied this area before, then do a bit of reading around end plates, because the end plate is actually a lot less tough than the annulus. So if you're going to get a herniation of this disc material, it can often be into the end plate. So either up into the vertebra above or down into the vertebra below. So the end plate is the top and bottom part of the vertebral bodies. Yeah, so you've got your vertebral body, and then covering the bottom and the top is this end plate structure. It's like a cartilaginous structure. And to give it the name plate is probably not the best description, because that makes it sound like it's walled off, like it's blocked. But actually it's more like a filtration system than a blockage system. So the way that your disc will get its nutrition is via the end plates. So through the blood supply from the vertebral body, and then there will be a capillary network going into these end plates, top and bottom, which will then merge across the end plate into the disc to keep the disc healthy. All right. So it's far from a plate. It makes it sound like, you know, it's just blocked off, but it's not at all. It is like a filtration. Here we go. So this might make it make a bit more sense. So you've got the vertebral body just here. So that's that section here. There's your nucleus. There's your annulus around the sides. So you'll have a superior end plate, which is the top of this vertebra, inferior, so the bottom of this vertebra. And then there's the blood supply within the vertebral body itself. You'll have little capillaries going up into the subchondral plate. Now, subchondral just means sub means underneath the cartilage. So that's your subchondral plate. And then you've got your cartilaginous end plate on the top, and then the nucleus on the top of that. So the way that your disc will get its nutrition is through this capillary network and then through that end plate. But this is a normal vertebral disc, nice healthy one. A degenerated disc will, the end plate will start to calcify. So then it will be a bit more like a plate where it's blocking the nutrients from coming through, because they won't be able to pass through as easily through this calcified end plate. But the thing to remember is a degenerated intervertebral disc doesn't just come with age, it comes with inactivity. So your disc age doesn't equal your chronological age. Yeah. So if you are very active, you keep yourself fit and healthy and eat well, don't smoke, and limit all the bad stuff in your life, then you will have a very healthy body, and the structure of this region will be better in those that have looked after themselves. So just because you're getting older, it doesn't mean that it's going to be really bad. It's like that image of the triathlete that's I think they're in their 80s, and that they've always trained, and their quads are really, really strong still. They've got really good musculature in their quads. And then you've got someone who's a sedentary 80-year-old where the quad region, or the thigh, is just full of fat. So if you exercise your body, it will keep healthy for longer. Okay. So we've got this cartilaginous end plate, a thin plate of hyaline cartilage lining the vertebral bodies at the disc. So it's this lining on the vertebral bodies, top and bottom. It functions to prevent the well-hydrated nucleus pulposus from bulging into the adjacent vertebra. So creating these little dips. Yeah. So like I said, the annulus is really strong. If you get a compressive force coming through your vertebra, then that disc material is more likely than coming out of the annulus to go through the end plate. Okay, so through these bits here, and I'll show you a picture of those in a sec. It also functions as a pathway of diffusion for nutrients and waste products passing between the disc and the vessels located on the osseous, so the bone side of the end plate. So we've got all these blood vessels on the bone side, and the nutrition for the disc will come from that area and pass through that end plate into the disc. Okay, so that's how it gets its nutrients. So the structure of the annulus, as I was saying, it's multi-directional. Yeah, so we've got consisting of 10 to 20 highly cross-linked collagen rings. Obviously they differ depending on where they are in the body, and each ring will be orientated in a different direction. So you may get some going vertically, some going horizontally, some going obliquely one way, some going obliquely in another direction, and that's what gives it its integrity. So it can distribute loads from all different angles and all different forces. Organized into a layered arrangement. Annulus resists tensile forces produced during bending and twisting of the vertebral column. Yeah, so it helps to maintain that disc integrity. Functions to contain the nucleus pulposus during compressive loading, and the outer rings of the annulus are the only disc structure innervated by sensory neurons. Interesting. Okay, so remember that for when you're doing your examinations of patients. So a small disc herniation through those innermost annulus fibers may not be felt because there's no sensory neurons there. But when it gets to this area here, then they may be felt. Okay, so yeah, it's I think that's quite an interesting thing to learn as well. This is a nice image, so you can see the different cross links of all the different annulus rings, and then the nucleus in the middle is well hydrated. It's amorphous, so there's no clearly defined shape. I think in some books it's like a sphere. So you imagine it being like this ball, and then when you push it, it deforms in certain directions, and that's really not the case. It's not a well, there you go, it's not a defined shape. It's like a blob of tissue. Substance contains a small percentage of randomly orientated collagen fibrils, a bit like porridge or phlegm consistency. That's a nice image whilst you're having your breakfast. So how do discs deal with forces then? They when you load a vertebra axially, so through its column, top to bottom, then we get this squashing of the disc and the nucleus, and as it gets squashed, then the forces get absorbed by the structures around that disc. That's what should happen. Okay, but as we know, as we've just talked about, just move me there, we can get problems with the end plates. Yeah, so axial load is just distributed into the annulus and the end plates, because obviously as you squish it, the nuclear material is creating force on the top and bottom of the vertebra that it's attached to. The annulus is really good at dealing with these forces. The end plate is not so good. So what we can get is these little herniations into the end plate, and they're called Schmall's nodes. So if you have some imaging done, you might see these little dips in the vertebral bodies, and that's because the disc is herniating, if you like, into those end plates. The end plates are more likely to give first with increased axial loading. The nucleus herniates upwards or downwards into the vertebral bodies. Yeah, so it can either be pushed up or pushed down. It just depends. So discs are often described as shock absorbers, and they're not really shock absorbers. They're more like a distributor of force rather than an absorption. So they don't just receive the energy and keep it in them. They distribute that load throughout the structures that they're connected to. And you've just seen on some of the cadaveric images that they're connected to a lot of different structures. And so there's a lot of distribution of forces if everything is working as it should be. Now, this is probably one of the biggest issues with thought processes around about moving with disc problems or creating disc problems, because they don't move like we are taught that they do. So the annulus is weakest and thinnest posteriorly. So I said that already. Yeah. So the bit at the back is the weakest and thinnest part of the annulus. The posterior annulus is also less pliable, so there's not as much flexibility in that posterior section. Flexion causes an anterior bulge of the disc. So if you look at this here, so if I bend forward, the disc actually bulges at the back, at the front. Oh my God, I've just said it. We're always taught it bulges at the back, yeah, but it can do, but it's more likely to bulge at the front. So we get this kind of, a bulge anteriorly rather than posteriorly. But in everybody's mind, it's the classic jam donut, where you squidge the front of the jam donut and then the jam comes out the back. And that's not actually the case with the disc on the whole. Obviously that can happen, but usually it will bulge anteriorly when you bend forward. Extension, you usually get a posterior bulge. So when you bend backwards, that's when it bulges at the back, usually. Okay, again, it's not always the case. It depends on pathology, morphology. So, but on the whole, bending forward, your disc will bulge forward. Bending backwards, your disc will bulge backwards, which goes completely against that jam donut analogy, which loads of people use. And also, if you have a disc bulge posteriorly, people usually are worried about bending forward because they're worried about the jam coming out the back, whereas that's not usually what happens. Okay? So it's not as clear cut. And when we were doing examinations where we learned this, that if someone bends forward and they have pain in their back, reproduces their symptoms, then it's a disc problem. And if they bend backwards and there's pain, then it's a facet joint problem. And we talked about the facet joints a couple of weeks ago. But it's way too simplistic to think that. And I think Ben Cormack posted a picture the other day. He said, you're getting these things where it goes through the differential diagnosis for back pain. And it goes, oh, if it's here, then it's a facet joint. If it's here, then it's a rib, and blah, blah, blah. But actually, it's not as simple as that. Okay, if there's an injury to that site, then it might be where is injured. But pain is a different ball game to injury. So just because someone bends forward doesn't mean it's their disc bulging at the back, because as we've just seen, usually they bulge forward. And same with the backward bending, doesn't mean it's a facet. Yeah, it can be some other things. So way too simplistic, and it's incorrect simplification according to the usual biomechanical loading of the disc, which we've just seen. Well, when I first found that, because that was basically how I was taught, was that very simplistic model, and it's really not the case. Right. So let's have a look at some herniations and the different grades of those. And then I think it was Jane last week asked the difference between bulges and protrusions. So we're going to talk a little bit about that as well. We should have enough time today. So this is a type of herniation is a radial fissure. So we've got a bursting through of the nucleus pulposus through the annulus rings. And like I said, posteriorly is where the annulus is weakest. Okay, so you're more likely to get these fissures posteriorly than you are anteriorly. It doesn't usually all happen in one go. Yeah, so this may be happening over some time, unless there's some kind of, again, pathology or inciting event that's caused a big herniation really quickly. The integrity of the annulus changes from the inside to out, and the nucleus starts to creep through these layers. So you can see grade 1 there, just a couple of annulus fibers have been breached, grade 2 a few more, grade 3. Now this might be the area where grade 3 and grade 4, because these are innervated by sensory neurons, these are the bits where people might start to feel it a bit grumbly. But here and here, you might not feel anything at all, because there's no sensory neurons in that inner portion. It's a bit like the meniscus in that way, where you can injure the meniscus in that inner portion because it's avascular, there's no blood supply there, and the innervation of that area is usually very low. So you can have some kind of sensation that something isn't quite right, but may not be painful. Okay, especially with a meniscus if it's catching. So how do discs survive? Right, this is how they get their nutrition. Only the outer few millimeters of the disc have a blood supply. Okay, the end plate is not closed off, so we talked about that. It's more like a filtration system than a plate. It's not like a block. The nutrients from the vertebral body are drawn into the disc via something called protoglycans. These protoglycans are negatively charged and they draw in water and nutrients from the bone marrow. So this picture that we saw before, that is how we get the nutrition into the disc, because of these protoglycans drawing the fluid into the disc, keeping it hydrated. We've got chondrocytes, which are cartilage building cells, and they help to build the disc and maintain the disc. And then we've got these matrix metallopeptidases, MMPs. These are enzymes, MMPs enzymes, and they clear away waste. All right, so we've got these three things all working together. And if you've seen this presentation before, then you'll hopefully remember this slide. So we've got these protoglycans, which are your delivery network, your chondrocytes, which are your friendly builders, and then your MMP enzymes, which are your waste collection, your refuse collection. And all three of those are working together in a healthy disc to maintain that disc integrity. That's what they are there for. Okay. What happens when we get old? Well, like I said, not just chronologically old, but old because we're sedentary. All right. So our delivery network will reduce. There's fewer delivery vans. Our chondrocytes, so our builders, they reduce as well. But the waste production enzymes, the MMP enzymes, will increase. So you get this shift from a building state into a clearing state. And that's what happens as we get older. And this is shown in MRI studies that are done in normal people, asymptomatic people, where they looked at the changes in disc structures depending on how old you are. So discs get bigger and thicker. End plates will shrink when compared to the rest of the disc. It's harder then to get nutrients to the disc. And then as we get older, the annulus takes up most of the slack for the force distribution. Okay. The bonus is, though, older discs are less likely to herniate. Yeah, so we would not usually have herniations, as especially in the 70s and 80s. It's doesn't usually happen. Okay, so it's always less likely to. So discs love movement, and that's been our mantra for years. Movement is medicine, and a lot of my patients will probably heard that to death. So healthier discs love movement. Less healthy discs if you're sedentary, okay, and you don't move around so often. This could also be an injury layoff, so you're not moving as much because you're injured. So if you've got some kind of leg injury, if we can still move around and create some forces through the spine, then that will maintain the integrity of those structures, as long as we can do it without aggravating other areas of the body. So I think we'll leave it here before we pick up next week. Disc aging doesn't equal calendar aging. Okay, they're different, and the fitter and healthier you keep yourself, the better it will be for your discs. Okay, there you go. So I will see you next week. We'll do the rest of that session, and then I'll do I want to introduce some of the nerve root stuff anatomy wise before we move on to sciatica, but they all kind of link in together. So we'll do a little bit of a recap on the spinal discs next week, and then we'll have a look at how discs herniate. So that will be next week, and then we'll start to move into the some of the other structures. Yeah, exactly, Tris. That's everybody's worried about deadlifts because of the jam donut thing, but now you can see that's not the usual biomechanical way a healthy disc moves. It's there you go. You can tell all those people that doubt deadlifts. Right then, I'll see you next week.